Hello, my name is Sophie Lee, and today I'll be representing my team, the International Strategy and Reconciliation Foundation, on presenting the topic of tuberculosis in India and engaging the public and private healthcare sectors. These are the co-authors of our research, and please note that all authors are affiliated with the International Strategy and Reconciliation Foundation. Here we have an outline of today's presentation. First, as an introduction, I'll provide a brief background on tuberculosis in India and the healthcare sectors involved in this TB management. Next, I'll go over our main research questions and methodology. Then, I'll support our findings with data visualizations, and lastly, I'll conclude and discuss suggestions for future research. According to the WHO data, in 2015, there was an estimated number of 10.4 million new TB cases worldwide. There was also an estimated 1.4 million TB deaths, and although this number did fall by 22% between 2000 and 2015, TB remained one of the top 10 causes of death worldwide. 60% of TB cases around the world occurred in 6 countries: China, Indonesia, Pakistan, Nigeria, South Africa, and India, the focus of our presentation today. The map on the slide shows the estimated global TB incidence rates in 2015, and the darker the shown color is, the higher the incident rate is in the area. Although this map shows that there are many countries with higher TB incidence rates than India, according to the WHO data in 2014, India has the world's highest incidence of TB in absolute numbers at over 2 million cases per year. This is over double the incidence of the second highest TB burden country, Indonesia, which has about 1 million new cases per year. Despite efforts, there has hardly been any decline in TB incidence. The green line on the figure to the right shows the incidence of TB in India in cases per 100,000 population per year. As you can see, between 2000 and 2015, there's only been a very small decline in incidence. An important contributing factor to the mismanagement of TB is the structure of the healthcare sectors. In India, the private sector plays a large role in providing healthcare, but there's a lack of coordination between the public and private healthcare sectors. Most public sector providers are under the Revised National TB Control Program, RNTCP, an initiative that was launched in 1997 by the Government of India. Under this program, TB patients receive a type of treatment called Directly Observed Treatment Short Course, DOTS, the internationally recommended TB treatment strategy by the World Health Organization. The private sector, on the other hand, is a continuing source of mismanagement of TB. This is mainly due to the fact that it is highly unregulated. Private practitioners do not need to report TB cases, which makes data collection difficult, and many of them use inaccurate methods such as serological tests and X-rays to diagnose and treat TB. This is extremely concerning because over 50% of the nation's TB patients go to the private sector for treatment. In order to engage all relevant healthcare providers, the RNTCP has been implementing public-private mix (PPM) projects, part of WHO's NTB strategy in various regions of India. These efforts began in the late 1990s and have continued to be expanded. PPM projects are the focus of this research. PPM interventions usually involve educating private practitioners about the RNTCP and DOTS, providing them with TB drugs free of charge, and ensuring that they report data in accordance with the RNTCP guidelines. Typically, institutions such as public medical associations and NGOs act as intermediaries between the government and the private sector to facilitate the collaboration. We will now explain the 3 core metrics that are used to evaluate the effectiveness of PPM interventions. The first measure is case notification. Case notification is defined as the number of new and relapsed TB cases notified in a given year per 100,000 population. It is important because notification means that TB patients have been diagnosed and reported under the National Surveillance System. This notification rate is based on administrative data. Note that notification rate is not the same thing as incidence, which is defined as the estimated number of TB cases arising in a given time period. For the case of India specifically, notification means that a TB patient is under the RNTCP and will receive the DOTS treatment. Then how is case notification an indicator of the effectiveness of a PPM project? Private practitioners are not required to report any data, so any cases they treat will not be part of the case notification rate. Effective PPM projects bring private practitioners and other relevant providers under the RNTCP, causing the case notification rate to increase. This is a positive change as the chance of treatment success is higher under the RNTCP than without the program. The next measure used to evaluate the effectiveness of PPM projects is treatment outcome. Some of the key treatment outcomes include cured, treatment completed, and treatment success. First, cured means that a pulmonary TB patient with TB at the beginning of treatment is smear or culture negative in the last month of treatment and on at least one previous occasion. Next, the term treatment completed is used when a TB patient completes treatment without evidence of failure but with no record to show that sputum, smear, or culture results in the last month of treatment were negative. Lastly, treatment success refers to the sum of cured and treatment completed. Other outcomes on this table include treatment failed, died, lost to follow-up, and not evaluated. Effective PPM projects will have a similar or higher treatment success rate than just the public sector or just the private sector. The last measure used to evaluate the effectiveness of PPM interventions is cost effectiveness. But first, we'll briefly describe the costs involved in implementing a public-private mixed project. The startup costs of an intervention include sensitization meetings and training sessions for providers and sometimes survey costs as well. Once the project is put in place, there are recurring costs that are related to monitoring, diagnosis, provision of TB drugs, and providing incentives that are usually non-financial for providers to adhere to DOTS. Now, going back to cost effectiveness, there is no set definition for this term, but it typically takes into consideration the number of cases detected, the number of patients successfully treated, the increase in the number of patients successfully treated, and the cost of the intervention from multiple perspectives. Cost effectiveness is usually reported as cost per patient successfully treated and is a useful measure because it is a strong indicator of whether an intervention is worth continuing or not. Effective PPM projects will have a lower cost per patient successfully treated than in the public sector or in the private sector. The purpose of our research is to evaluate the effect of PPM projects on India's TB treatment efforts. We focused on the following questions to guide our research. First, what is the effect of PPM projects on case notification? Second, what is the effect of PPM projects on treatment outcomes? And lastly, to what extent are PPM projects cost effective? As we answer each of these questions, we will present data visualizations to contextualize our findings in addition to explaining the India-specific data. One of the first steps that we took in our research process was to conduct a metadata analysis of the three measures that we mentioned, which are case notification, treatment outcome, and cost effectiveness, to evaluate the effect of PPM projects in India. The main sources of data that we used include journal articles published between 2003 and 2015, the Government of India's Central TB Division annual reports, the World Health Organization, and the World Bank Data Catalog. These include survey and administrative data. Then we reanalyzed data from research in India comparing PPM and non-PPM outcomes, and we combined data from the various sources. Finally, we created data visualizations such as data maps and interactive DVs to communicate our findings. Now we will present our major findings. Here we have an interactive data map that shows the different PPM projects that have taken place or are taking place in India. We will give a brief summary of how each project was implemented and maintained. In Bangalore City, the intervention took place in 2 stages. Phase 1 began in 2001 and focused on involving large institutions such as medical colleges and public hospitals. Phase 2 began in 2003 and was an intensified effort that sought to involve additional providers. In Delhi, the Delhi Medical Association was responsible for serving as a bridge for the private practitioners. This project began in 2001. In Hyderabad, the Mahavir Charitable Hospital was responsible for being an intermediary between the private sector and the government sector. The intervention began in 1995 and was expanded in 1998 to cover more people. In Kannur district, located in the state of Kerala, in the intervention, private laboratories were surveyed and trained to provide DOTS beginning in the early 2000s. In Mumbai, Maharashtra, the intervention was aimed at private providers as well as public providers who were not yet under the RNTCP. 3 NGOs were responsible for facilitating the project, which began in 2002. There were also interventions in the cities of Meerut and Chennai that are not included in this presentation. Now we will present findings of PPM in relation to case notification. We have identified 3 studies of PPM intervention. First, when the intervention started in 1995 in Hyderabad, it covered 100,000 people. The case detection rate increased steadily in this initial phase, and when the project was expanded to cover 500,000 people in 1998, the detection initially fell but soon started to increase again. In Mumbai, there was an increase in the case notification from previously uninvolved parties. While cases notified by parties originally involved in the RNTCP remained stable at about 45 per 100,000 population, cases notified by newly involved parties increased from 0 to 17 per 100,000 population. In the experimental region of New Delhi with a PPM intervention, the overall increase in case detection in 1 year for all new cases was 131%. In the control region with no PPM intervention, this figure was 26%. This line graph shows a trend of TB case notification rates from 2000 to 2015. It can be seen from the graph that the total number of case notification rates, which is represented by the green line on the top, has been on the rise since 2000, reaching 1.4 million notifications in 2015. Please take into account that this graph does not include the notification rates of multi-drug resistant TB, TB HIV, and other complex types of TB. Now we will look at the impact of PPM projects on treatment success rate. In Bangalore City's PPM intervention, there were 2 parts, initial phase 1 and an intensified phase 2. Treatment success rate for cases reported under the RNTCP increased from 86% pre-PPM to 87.3% in phase 1 and 87.99% in phase 2. In Hyderabad, researchers reported that treatment success rate was 94% under PPM DOTS, 83% under public DOTS, and 51% under private sector non-DOTS. Overall, PPM DOTS successfully treated 40% more cases than public-only DOTS and 85% more than private sector non-DOTS. And finally, in New Delhi, treatment success rate for all cases was 86% under PPM DOTS and 51% under private sector non-DOTS. Overall, PPM DOTS successfully treated 69% more cases than private sector non-DOTS. This stacked bar graph shows the impact of a PPM project in Hyderabad on treatment success rate for new smear-positive cases from 1998 to 2002. The blue represents treatment success and the orange represents treatment failure, death, or default. The x-axis shows the treatment provider and the y-axis shows the treatment success rate as a percentage for new smear-positive cases. As you can see, the bars are placed in order of decreasing treatment success rate. For the first bar, we have PPM dots with a success rate of 96%, and for the last one, we have private sector non-dots with a rate of 51%. This graph presents treatment success data in a way that allows the viewer to grasp the implications very quickly. It is clear that with this intervention in Hyderabad, PPM was able to successfully treat a much higher proportion of TB patients than either a public-only or private-only scenario. The data suggests that an intervention implemented at the city or state level would yield promising results. This line graph here shows the treatment success rate from 1995 to 2014 for new TB cases in 6 of the world's highest TB burden countries: China, India, Indonesia, Nigeria, Pakistan, and South Africa. The purpose of this graph is to help you understand the context of India's treatment success rate over the years. We can see that among this group of high-burden countries, India, represented by the gray line, had the lowest treatment success rate in 1995 at 25% and also in 2014 when the success rate was 74%. However, it is clear that India has shown the greatest improvement in treatment success rate over the time period. One observation that can be made is that the trend in treatment success rate for India is quite different from that of the other countries presented here. For example, China's success rate, represented by the red line, has remained stable and above 90% since 1995. And India's treatment success rate starts to increase significantly beginning in 1999, where the circle is on the graph right now. This can most likely to be explained by the implementation of the revised National TB Control Program. This is also around the time that PPM projects began to emerge. Now we will present the cost-related findings from 3 interventions. First was in Bangalore City. Here, Pantoja et al. Administered a questionnaire to study participants and found out that patients spent an average of $145 before entering treatment under the RNTCP. This figure includes the treatment cost of $127 and the cost of travel and missing work. This represents a significant waste of resources as treatment costs under the RNTCP are only $21. In terms of cost effectiveness, it was found that the average societal cost, a figure that takes into account costs to providers, patients, and attendants, decreased in the 4 years following the implementation of the project. It was also found that the average cost per patient from the provider's perspective was lower as well in the intensified PPM phase than in the pre-PPM phase. In Hyderabad, Floyd et al. Found that the average cost per patient was the same in PPM and in private sector non-dots, so PPM was found to be at least as cost-effective as private sector treatment. Floyd et al. Also assessed the cost-effectiveness of New Delhi's intervention and found that the cost per patient was lower in PPM dots, where the cost per patient was $123. In the private sector, this figure was $172. Clearly, cost-effectiveness is a very desirable trait for a public health project in any country, but is particularly crucial for India given the country's meager health expenditure. The figure on this slide shows the percent of total government expenditure that is spent on health for 6 of the world's highest TB burden countries. India is represented by the yellow line. The figure makes it clear that India spends a relatively small portion of its national budget on health compared to the other high TB burden countries. In 2014, India's health expenditure was comparable to that of Pakistan, represented by the dark blue line, at about 5% of total government expenditure. In addition, India's health expenditure as a proportion of total government spending has shown little change over the years despite the persistent problem of TB. India's budget for the for the revised National TB Control Program is also in need of increased funding in order to meet the scale of the TB problem. There was an expected tripling of funding for the RNTCP from 2012 to 2017, but this did not happen. Although India's TB budget did increase from 2012 to 2016 from $220 million to $280 million, the proportion of the budget funded by the Indian government has been decreasing. Given that PPM projects are usually more cost-effective than DOTS provision through the public sector only, they may be a good solution to India's lack of public health funding. So, what are the implications of these consolidated findings for policymakers? The studies we reviewed provide solid evidence to support the PPM approach to managing India's TB control and treatment. The data point to the positive effect of PPM in terms of case notification, treatment outcome, and cost effectiveness. However, although public-private mixed interventions seem promising, the large-scale implementation of PPM remains a challenge. In order to overcome this challenge, we present the following recommendations. First, trust building should be mature between public and private providers. The Government of India should continue to make efforts to include private providers in conversations surrounding TB and show them that they are key to solving the country's TB problem. Second, local administrators in India should conduct systematic mapping and coordination of private providers of TB control and treatment. Like mentioned before, the private health sector is highly unregulated. Private providers are not required to collect data or adhere to certain practices, making it difficult to understand what exactly is going on in the private sector. If local administrators carry out this mapping and coordination of the private sector, this would ease the process of reaching out to private providers and getting them involved in PPM interventions. Lastly, a reasonable amount of funding should be provided at the national level to implement PPM projects. Government funding has not been commensurate with the increasing scale of India's TB problem. Without adequate financial resources, it wouldn't be possible to implement even the most effective strategies. To conclude, PPM studies involving survey and administrative data are rigorous enough to provide evidence of the effectiveness of PPM interventions in terms of higher case notification rates, successful treatment outcomes, and cost-effective patient management. Future research should focus on using more survey data to better understand the TB patient population in order to provide more tailored interventions for different regions. In addition, future studies should strive to more effectively link survey and administrative data. Thank you for listening, and please contact me at the email address shown on the previous slide for any questions or comments. Thank you.